is, say, whatever the topics which we decide, right, they will be completed. So I never mistake them. And I think it is getting recorded by the. Will it be for all years? Well, at this point of time, yes, the plan is yes. Till you guys are interested. See, what really happens is that if the presence drops, so as it happened in the last year also, if the presence drops, then we are forced to discontinue the class. Because if the presence is less, then it doesn't make any logic. So yes, that would be very crucial. Because otherwise, so everything is available. So that's what I'm telling. See, those who really want to genuinely attend the thing, I even in my USMLE class, I don't record it because it's like the importance of what is the importance of that talking to you live. Otherwise, so everything is available on the internet. Absolutely, all these PDFs they are stored and on cloud. So just send me a mail at till you are MBBS, right? I'll just write every time. So let me put it over here. So if you got that email address, all these PDFs are there. Till you are MBBS. So send a mail to me and I'll send you the link. And all the PDFs they'll be lying over there. I know last time it happened like there was for one or other reason the presence started dropping. And I used to get the emails also that many of the seniors are telling that no, it is not necessary to study in this month, etc. This is medical. So I always say learn as much as possible. You'll be very much benefited as you go in the long run. Okay, it's 10:33 and it's time we start. So what we shall be discussing? Two major things. We'll be starting with, again, those pressure. We'll be learning something more about the pressure and important concept of surfactant. Then we'll be learning about one law of physics. And then we'll go to X-rays. And in that X-ray, we'll compile everything and we'll see something so amazing, right? Which can lead to incorrect diagnosis. But then when you realize it, that yes, it is based on these things. So very interesting session is going to be. Let's start with the way we start. That is the trachea, right? This is the trachea. And that trachea has got the rings, correct? And then it divides, right? It keeps on dividing. That division, if you say that trachea is level 0, right? Trachea is level 0. No, why should not be low? No, it should not be low. Because if it is low, then everyone would have said. Just check your settings. Because over here, as I told you last time also, that this is how I get it, right? Say if the voice is low, so then this meter will show me immediately that it is going low in decibels. Kindly check the settings. So on to this trachea, if we consider this is level 0, So then all the way, as they keep on dividing, right, they will be dividing till the level 23, right? So many times. So this is first division, right? Then this would be dividing it to two. So this is level 2 division. And once again, this will divide, right? So that would be the level 3 division. So that way it will keep on dividing till 23 levels, right? Out of these 23 levels, if you really put it like this, 716, and just next it will change to 16.7. What means that? Means what? That these level 7 up to the level 7, when they divide, you cannot compress them. They are not compressible. That means they are like tough tube, right? Tough tube. They need to be tough because these are the cartilage, right? Over here, these are the cartilage. So there is cartilage is present, right? Those cartilaginous ring, that is present. So if the cartilage is there, the cartilage is a tough structure, it won't allow it to collapse. What about rest of the 16? These rests, as we go deeper, they are compressible, right? They are compressible. So that is a different characteristic. And they are compressible to find the cartilage. So if there is no cartilage, then who will be compressing it? Smooth muscles, right? So there would be presence of smooth muscles. Right? These smooth muscles, they will be controlled or they will be handled by whom? Who will be sending them? Who will be telling the receptors? Right? Who will be telling the brain that okay, now it is time, or there is decrease or increase in the oxygen? Right? Chemoreceptors. They are needed. So they will be present over there. There are some very specific cells. They are called as the neuroendocrine cells. They are present only in the last 16th level, right? Last 16. These are the first 7 levels, and these are the last 16 levels. So in the last 16 levels, we'll find all those neuroendocrine cells. Now there are many. So that is what is called as the decarboxylation. So this is amine precursor uptake and decarboxylation. Then there are some very specific cells. They are called as the Vater cells. Or there are one more that is called as the Kulchitskis cells. All these are basically neuroendocrine cells. But these cells, they are present in these last 16 generations or the levels. Still more importantly, the topic which we'll be discussing next, and that will be all the volumes, right? All the volumes, etc. Our timing is 10:30 only. It's 10:30. Okay. Those who are present over here, I don't mind. Right now we are starting as per the Indian time at 10:30 a.m. Is it okay to start at 10 a.m.? I don't mind. But yes, I got few. 11 a.m. You want to delay it or you want to take it early? Because delay won't be possible. Delay would be difficult. Okay. So right now we just keep it. Then later discuss. Because important time would be wasted. So much ground is to. Trachea. What we said is trachea, and the trachea is like this is trachea. It divides into, it is called as the primary bronchus. Primary bronchus, it divides, and then it is called as the secondary bronchus, then tertiary bronchus, right? Then bronchioles, and then finally divide, and last there comes the alveoli. So this alveoli is the last level, right? But that's how they keep on getting. divided. Right? I hope I'm clear. Right? So these generations or these levels, they are nothing but how many times they keep on dividing. Right? One important thing what I was talking about, that is the volume. That means the air which we breathe. This is the alveoli. Right? Over here, this is oxygen. Over here, there is carbon dioxide in the capillaries and the gas exchange. But what about the trachea? Right? These are the bronchial division levels. That's right. So what about the trachea? The air which is present into the trachea, can it do oxygen CO2 transfer, gas exchange? No, right? It cannot. It cannot. So this is very crucial. Point is that when we say that there are 23 levels, right? 23 levels. Out of these 23 levels, last time we divided it into 7 and 16 over here. Correct? 7 and 16. This is 7, this is 16. Now, make it reverse. This is first 16 levels. 16 levels. They are like dead space. Dead space. What is dead space? Dead space means it is the air which is present into this region. It won't be allowed for the oxygen CO2 exchange. Why? Because there are no capillaries outside. There has to be a capillary. There has to be a blood supply, and there has to be a blood which can really exchange it. So up to first 16 levels, right? When this is the trachea, it divides, right? But over here, the air which is present over here, that air is useless practically for our body. It is only when it divide. So only in the deeper layers, in the divisions, then the oxygen, carbon dioxide, that is the gas exchange starts. So gas exchange, it occurs only in the last 7 levels. Only in the last 7 levels. That is where the gas exchange occurs. Otherwise, rest of the space, this is a term which is used, and it is called as the dead space. Dead space. Right? Do you remember this dead space? Dead space means whatever the air which we breathe. Right? Now think it like, you need to visualize a bit. Let's say you are breathing 500 ml of air. So that 500 ml, let's consider right lung. Right? Forget about the left lung. 500 ml has entered. But that 500 ml, right, some of the air would be into these first 16 levels. So the air is there. And then some air will reach to these last 7 levels. And they will start exchanging the gas. Right? And then what happens? We do expiration. So when we do expiration, still there was some air into the path. And then the air which is into the lungs, it is pushing it back. This is the reason that what we breathe out is not 100% carbon dioxide. There would be oxygen also. Because when we took the breath, right, the air which was going, the oxygen which was present over here, right, it never got a chance to get exchanged, right? Before they could reach to the alveoli, the air which was in alveoli, usne ulta dhakka mara and chalo sab bahar, right? So, and then they came out. So this is our body. Important concept is dead space. If this dead space increases for any of the reason, that means even the person is breathing, but he's not getting the oxygen. His tissues are not getting the oxygen. Is this concept clear? Because today I'll be going step by step. Don't they understand it? I don't feel good keeping everyone on mute. Anyway, right now I am allowing participants to unmute themselves. So in case if you want to unmute and ask anything, you can, but regarding pathology, I'll discuss. So out of the 100% inhaled air, only 30% used for exhaust. Yeah, that's right. That's right. Not actually 30, it is more than 30%. But yes, only a portion of it is used. 100% of the air, whatever we breathe, it can never be utilized because the amount of air which is into the dead space, it has to return before it can get exchanged. correct? So at times I use this very crude comparison, right? So here is nowadays, so it is, everything is online. Acha, no problem, no problem. Level, which part, no, be specific. I said two things about the levels. One was that it is the first 7 levels, that is where the cartilage is present. Okay? The first 7 levels, cartilage is present, so they are not compressible. They are like tough tubes. And rest, they are compressible, so they can constrict. Why should they constrict? There are presence of smooth muscles and there are no cartilage. So there are no cartilage, so that means they can be compressed. And then out of those 23 levels, first 16 levels, whatever the air which is present, right, that cannot be utilized by the body. That has to return. So, you know, in theaters, there was a ticket window, right? And then wo lambi line lagi. There is long queue, there is long. So, if there are 50 tickets, line mein 150 jane lage. But those 50 people first, they will get the tickets and they'll say, chalo, chalo, sab wapas. So these guys, they will not be getting the ticket and they have to go back. Same thing happens. Right? If you elongate the whole thing, right? All the oxygen, right? Chalo, 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 exchange can they come. And then till inspiration, everyone is allowed to go in. And then the expiration. So only these, like they got that exchange and they got the carbon dioxide and return. So all of them, they also have to return. And this is what is called as the dead space. Dead space. Just keep this concept. Right? So this space is what we'll be understanding in more detail as we'll be discussing the pathology and so many other concepts. So this is first thing what was necessary. When all leaves, that is the dead space. Another important thing, there are cilia, right? Just consider that the cilia are what these are like. Just consider that these are like grass, right? They just move like this. They keep on moving like this. So in our entire respiratory system, there is a formation of mucus. Mucus. So it is these cilia, they will keep on throwing the mucus out. Right? They'll keep on moving and they'll keep on throwing the mucus out. So that mucus is going out. That is this is a hypothetical. Things which are not possible, what's the meaning of that? What would happen if we were able to exceed 100%? I don't know. You are more intelligent. You should be able to answer. I don't have the answer of that. Because how is it possible? How can you exchange the gas in the trachea, which is like a tough tube, right? Surrounding there are only esophagus, right? There is nothing else. So how to do the gas exchange over here from the trachea level? No idea. I don't know. So this mucus, when it moves, this is important. It throws this mucus out, right? Because if the mucus is there, and here it is, this is the alveoli. If the mucus remains present over here, so then what would it do? It will increase the wall thickness, right? There is a layer in between. So this layer will be a hindrance. It will be an obstruction for the oxygen to go out and the carbon dioxide. Possible, right? Very difficult. So this is the reason that these cilia, they'll keep on taking the mucus away. That's right. That's why the mucus collects, right, when we have got cold. So as people, right, many times you must have seen that people cough so vigorously. Right? So it is that cough, right? It is cough. And see, there is a difference between medical terminology and what people say. In medical terminology, I'll use the word Hindi so that it's easy. Khasi. That is called as the coughing. And the substance which comes out, it is called as the sputum. While the patient would say, Doctor Sahab, bahut cough nikal. So what he means is sputum. बहुत खांसी आ रही, so that is the cough. So be very clear in what exactly, when we are talking medical, when we say coughing, coughing means right, not sputum. That's why there are two terminology: dry cough, right? When it is a dry cough means sputum is not coming out. There is no sputum. Clear? Okay. So that's sputum. Yes, you are right. That in common cold, when people really cough heavily, so that is that sputum, it comes out. Sputum. Sputum is S-P-U-T-U-M, right? Sputum. Hindi mein what is called as balgam. That is the sputum. And then sputum itself is a huge topic, especially when we'll be learning in medicine, right? Whether that sputum is having blood, whether it is yellow color, whether there is, it's everything, right? There is a large amount of, say, diagnostic things associated with the sputum. But that sputum is cleared by this, that is what is called as the mucus when it is inside, right? It is mucus. Cilia works actively, so they throw this mucus out. Mucus is a normal process which will always be present normally. Every time it is getting made and then it is pushed and pushed and pushed out. This is a mucus. Blood, in case if there is any injury, if there is any tumor, so whenever there is a tissue break, so there will be presence of mucus. Mucus means when it is inside the lungs. Sputum is what comes out. Clear? So this mucus, so this entire mechanism is called as the mucociliary mechanism. Correct? Mucociliary mechanism. This mucociliary mechanism, that is relatively quite weak in the last 6 regions. That is weak. After that, it becomes more powerful. So this mucociliary mechanism, or the clearance that is weak, in last 6 levels. That's why when we shall study the entire histology, we'll find that yes, the ciliary system that is extensive into the large tubes, right? Because they just clear it, and nothing remains get collected over there. That's why, so when there is coughing, people have to cough vigorously so that sputum, it is pushed out. So one another. Now comes the concept of what's called as the surfactant. As we said, that every time it happens, like lungs, they are interested in collapsing, chest wall is interested in formation, inflation, right? Inflate. So there is a game of inflation and the deflation, correct? Surfactant, this is one substance. If this substance is not released, so then it would be impossible for the lung to expand. So over here, say, there are specific cells, they are called as the Clara cells. You will find these Clara cells, they are present into middle, lower levels. Okay? You will not find much of the Clara cells in the trachea, in the primary bronchus or the secondary bronchus. They are much deeper. So let's say they are present in middle or why should it be like this? Because that's the area. That's the area where we need to say, we need to keep them open. Otherwise, say those trachea will never collapse by itself. Trachea will not. Trachea will always be, because it is a tough ring, cartilaginous rings. So these Clara cells, they need to release off what's called as the surfactant. Now this surfactant, it is interesting to know. You know, we said that there is Clement test. Clement increment test, which is the indication of, or the bubble test, also called as the shake test, where we are testing the proteins. We are testing the proteins, and that is leading to lung maturity. So this surfactant, it appears, right? It appears, that is the synthesis of it appears in the 20 weeks, when the baby is of 20 weeks. And then by the time it reaches to the 28 weeks, it is active. So that's over here. Synthesis starts. Body starts its synthesis at 20 weeks. Right? And by 28 to 32 weeks, when they say that okay, lungs are matured, right? So now, even if the baby is to be delivered, no problem. That baby will survive. Otherwise, if this surfactant is not there, they will not be able to survive. That's right, to fetal lung maturity. Right? So this is present in middle and the lower levels. Present in middle and lower levels. You must be remembering that we talked about intrapleural pressure. Intrapleural pressure. So in lungs, they are covered by two pleura, two layers of pleura. This is the lung, this is the lung, this outer one, that's the covering. So over here, this is the lung. Then the layer which is outside, it is called as the visceral pleura. And this one is called as the parietal pleura. We are adding something to this. This pleura, this is not the fluid which is always present, right? It's not so that it's the same fluid which is always present. This is a very dynamic system. This fluid is made and absorbed constantly. Yeah, there is negative pressure, but the formation of the fluid, the formation of this fluid, that is like a continuous process. So it is the parietal pleura which will secretes. Parietal pleura secretes, and visceral pleura absorbs. So visceral pleura will absorb. But still, if there is any excess fluid, sometimes it happens that if there is more secretion, so excess fluid or the excess pleural fluid, it goes into lymphatics. So these lymphatic channels, they are important from that perspective, that in case if there is any infection, so that infection would also be carried by the lymphatics. So this is one concept, that this intrapleural pressure, this pressure, you are right, that is negative. And it is over here where there is parietal fluid, and this fluid is secreted by parietal, absorbed by visceral, and any of the excess fluid, if it is there, so then that fluid, that is taken away by the lymphatics. So this is the next. When you will be telling the patient, at times you have to tell the patient for doing certain maneuvers. Maneuvers means you have to tell the procedure that do this exercise. So what would really happen in such cases? We are now talking about the pressure inside thoracic pressure. Very simple thing. The moment you will do it, you will automatically. I'll be telling you to do two maneuvers or two procedures. So this intrathoracic pressure over here, the first procedure, it is called as the Muller's maneuver. It's called as the This is Muller's maneuver. And another procedure which we will be talking about is the Valsalva maneuver. Now, all of you will do this so that you will automatically understand what happened. Muller's maneuver. This is called as glottis. So, do it this way. Say, suppose if you want to swallow, right? If you want to drink, what will you do? Right? And then you'll swallow. But what you have done at that time, you won't be able to breathe. Correct? Because that's the trachea. This is the esophagus. When the water is to be taken into the esophagus, so this area blocks so that nothing goes inside the esophagus. Right? That is what is called as the epiglottis. That is the function. Right? It goes this way or this way. And when you are breathing, right? So at that point, esophagus is closed. Very simple procedure. So over here, deliberately, as if you are swallowing, you close the glottis and then try to breathe. It is the forced inspiratory effort, right? You won't be able to breathe. Right? It is the forced inspiratory effort because glottis is closed, right? So you first close the glottis and then try to breathe, right? So when you try to breathe, right, you will find that there will be increase in there is intrathoracic pressure. Right? So there is increase in the negative intrathoracic pressure because when you are trying to breathe, you are trying to take air, the chest is expanding, right? Chest is expanding, but you are not letting the air go. So the pressure, negative pressure is built up. Right? So what happens in swimming? You go underwater, right? You go underwater, and you won't be able to breathe. So you have to close your glottis, and then you are just holding, but you are trying to expand the chest, and then as soon as you come out, right? So that's what really happens. So this is forced inspiratory effort with glottis closed. This is what is called as the Muller's maneuver, and in this we'll write that there is increase in the negative intrathoracic pressure. If you do it, you'll understand within a second. Okay. Now comes the Valsalva maneuver. These maneuvers we are talking about, because when we'll be discussing, next time we'll be discussing asthma, we'll be discussing COPD, chronic obstructive pulmonary disease, we'll be talking about bronchitis. That's what really happens in all these cases. And that's where we'll talk about when you tell the patient to do these maneuvers. And you'll see the differences. So in Valsalva maneuver, again close the glottis and try to do the expiratory effort. Close, right? And as if you want to just push the air out. So here your abdomen will go in, right? So the pressure is generated inside. So there is increase in positive intrathoracic pressure. So what I mean is forced expiratory effort. I'm telling effort with closed glottis. So if the glottis is not closed, so forced expiration, the air has come out, but you don't want to let it come. Close the glottis so that let the pressure build. Obviously, when the pressure build, that means it is increase in positive intrathoracic pressure. Right? Intrathoracic pressure. Clear? These two procedures you keep in mind. Okay. We said that this pleural pressure is negative. That's right. This pleural pressure is negative. But how much? When there is a quiet breathing, when there is quiet breathing, this is first I'm giving you the results, and then we'll understand a law of physics that is called the Laplace law. And then we'll see how to implement its importance. So when there is quiet inspiration, think it like that normal inspiration is going on, and then at the beginning, as the inspiration starts, right? Inspiration starts. The pleural pressure, this is something. And then when the inspiration ends, there would be some pressure. When we breathe in, right? Think it like when we breathe in. So those alveoli, they have to expand. Correct? So these alveoli, they have to expand. So in that case, whether this pleural pressure, that will increase or decrease. If I say that at the beginning, the pleural pressure is -5 millimeter of water. It is not mercury, right? The pressure is not the level of mercury, it is water. So 5 mm of water. This is the beginning. Now what should happen? It should become more negative, or it should become positive. It should become positive. We want to expand the alveoli. So we are dealing with this pressure which is outside. This pressure is negative. So what would we do so that these alveoli, they expand more? What should be done? So if this is -5, what should be when it is like this? Number doesn't matter. That's what I'm asking. That's what the question has been asked. The moment I'll tell the answer, you'll say, I agree. No, but I really want that you think on it. I want to inflate the... correct. Yes, Ishani. I want to inflate it. Right? Inflation means I want to expand it. I want to expand. This is from here to here. Right? This is stage 1 and this is stage 2. So I want to make the alveoli big. So can anyone pull it out so that air can go easily? Because air has got no power. Right? It is these other mechanisms. They will create the space and then air will come royally. Forget about quiet or forced. Right now we are talking about quiet only. Forced or quiet, what difference would be? Forced means there will be involvement of muscles. When it comes to this principle, it really doesn't matter. So don't complicate it. Simple. Intrapleural pressure. Yes. At the beginning of the inspiration, the air which is going in, right? At that point, it is -5. That means and then when it ends, the alveoli has become bigger. So what would happen to intrapleural pressure? I told you, pressure 1, right? Say if this is pressure 1 and if this is pressure 2, it was 1 - 2, right? So keeping this 1 minus and the pressure over here, let's say if I take -5, to avoid confusion, I'm just making this number. Or let's put the odd number 1.5, right? So this 1 is what? This one is the intra-alveolar pressure. And this 2 is what? This 2 is intrapleural pressure. So it is the difference 1.5 minus. So this will become what? 6.5. plus 6.5, because minus will become plus, so this will become 6.5. When this number is positive, that means there will be inflation. If this number goes negative, so that means it is deflate. But obvious, no? That's the chamber. So if the external pressure, right, it is compressing, so then it will collapse. If the internal pressure is powerful, so that will keep on inflating. But over here, we are dealing with this outside. So if I want to inflate it more, what should really happen? Now let's say if it becomes 1, right? 1 plus 1. So then what would happen? This is 1.5 minus 1 is equal to 0.5. What? This is 6.5 and this is this. The whole thing would collapse. It would collapse. The suction force thing is that this intrapleural pressure, it should become more negative. Right? It is like suction. That Tetra Pak, right? That straw which you are putting, and when you are consuming, you are picking up even the last drop of that fruity, right? So that the whole thing was collapsing. It is because your lungs, they were just generating the suction power so much, right? So over here, almost the same thing, hydraulic pressure, right? So this is what is pulling it out more. It is pulling it out more. That's why over here, when I write, so that would be like minus 7.5. Very, very important. Minus 7.5. Means those intrapleural pressure will become more negative so that it can really suck the alveoli more and more, so that more air can really come. Right? Interesting. But it should be crystal clear, because when we'll be talking about those COPD and then about all those restrictive lung diseases, this concept will be playing a big role in that. So I hope this thing is clear. This will be plus 9. This line. So this was like 6.5 to 9. It will inflate. Right? Now see what happens when it is. This is the lung. If you calculate this at the apex of the lung, pleural pressure, right? You will find this is minus 2, minus 10. And if you calculate at the base, you will find that it is minus 2. Over here, it is more negative. Over here, it is less negative because of the pressure of the lung. Intrapleural pressure, it decreases while inspiration. Very true. Because then and then it can really suck the alveoli and alveoli can become bigger. Right? It becomes negative. So that's why. Simple thing. Na? The only that number. This is pressure 1 and this is pressure 2. Pressure 2 is outside. This is 1. Right? And it is 1 minus 2. Right? Pressure 1 minus pressure 2. Let's write it like this. Pressure 1 minus pressure 2. If it is positive, it is inflation. So that means this will be become. Right? If it is negative. See? So you will agree that if this number, this P1, let's keep this number is 2.5 minus. If this number 2 it becomes bigger, so then what would happen? Say if it is 2, right? And in second state it becomes 3. You just calculate 2.5 minus 2, this is 0.5. And 2.5 minus 3 becomes minus 2. This number is decreasing the whole thing. When we know that this is negative, the negative of negative becomes positive. Doesn't matter. Doesn't matter. Principle remains the same. This pressure on timeline, this is 0. This is minus 5. So over here, you have to put such pressure because this will be 2.5 plus 5, that is 7.5. Right? And this is the beginning. This is the start of the inspiration. And now we want to expand. So we need to cross this number. So if 2.5 minus, I have to take this number more negative so that there is a suction force. And mathematically, I have to make this number minus, let's say, 7.5. Because then and then this number will become 2.5 plus 7.5, which is 10. Number must increase, then and then it will increase. And it makes sense also, right? You take a balloon and then you start blowing the air into that. As it becomes bigger, you are just blowing the air, right? So that it becomes bigger. How is the difference? How is the difference? When you do it the forceful way, forceful inspiration. With full throttle, and you do it in classical situation, when someone yawns, yawning means passing. So, right, that's so large amount of air is taken in. Why it is so? Because brain has sent a message. And brain requires more oxygen, so it takes, okay, take a yawn, right, and hold it down. So air is sucked in. Or sometimes people say, right, aisa ho gaya. So that is when the large amount of air, it's called as the feeling of sigh. Right? So over there, it becomes minus 30. See so much of it. Have you seen a kid crying? मतलब आवाज आनी बंद हो जाए और वो आंख बंद करके they cry. So that baby cry, when baby is crying at full throttle, minus 60. So much of it. And now see, what was Muller's maneuver? Muller's maneuver. Muller's maneuver was close the glottis and then try to improve inspiration. Now glottis has been closed, chest expanded, right? So much of negative pressure is generated inside. That is minus 100. This is inspiration with closed glottis. So these are some of the numbers, especially when we talk about this procedure. The next, what happens when you do expiration? When you do expiration, the classical physiology is when someone coughs. That is the forceful expiration. Or when there is sneeze. On sneeze, so we'll be discussing in length because how this sneeze occurs. Because the speed at which the air comes out, it is more than the speed of rifle. Right? Rifle comes out at the speed of about 350 kilometers. That is the speed. Right? So coughing, sneezing. So over there, it's 30 to 50, but plus that much. Because then and then air would be pushed out. Everyone would be contributing. The alveoli would collapse. The muscles are acting. Then they are generating so much pressure inside that air has to go out. So that is expiration, sneezing. And when you talk about this Valsalva maneuver, so Valsalva maneuver was doing what? Valsalva maneuver was doing what? It was doing that close the glottis and then try to push the expiration. Typical thing, right? If someone has got a constipation, it was that feeling. So when the pressure is generated, because this will generate tremendous pressure. So that is the pressure, it's plus 100 to 150. That's the pressure in Valsalva. So this is how things really go. Now we talk about one of the important concepts of when we say surfactant, right? Surfactant. Take a new page. We talked about surfactant. Do you remember the word pneumocyte? Pneumocyte means, pneumo means air, cyte means cells. These are the cells of the air, that means lungs. Three types, main three types, type 1, type 2, and the type. No, it is not related to pneumonia. Pneumocyte, these are the normal cells. Pneumo means air. Pneumo means air, right? So cyte means cells. So these are the normal cells which are present in human's body. So this type 1 and type 2, they are very crucial because the same number of cells, right? Same number of cells, whether they are 1 or 2. They both have the same number. But the area which they covered, the entire lung, being 93%. These are the cells. Pneumocyte means these are the cells. These are the cells. These are the cells which are responsible for gas exchange. Oxygen, carbon dioxide transfer is because of them. And these are big cells. Big. From size perspective. Type 2 pneumocyte, their area covered is only 5%. Area covered is only 5%. And what will they do? They synthesize surfactant. They synthesize surfactant. It is the surfactant which will form a layer, a thin layer, so that a surface tension is created, so that it won't allow the alveoli to collapse. See that. At birth, they are 100%. Why? Because the entire baby was into fluid. For baby, it was not at all needed to do any of the oxygen CO2 transfer, because things were coming via the cord. Correct? So that's why when the entire lung was dipped into the fluid, there was no need. So that's why there were only 100% of type 2 pneumocyte at the time of birth. And then they start getting converted. The first type 3, this is just 2%. These are just 2%. And these are all what is called as the chemoreceptors. These are the type of cells which are present for there. Now, what is this surfactant? What it will do? If we just say two important surfactant, one, it will decrease the surface tension. Decrease the surface tension. And second is, it will increase the ability to distend. So there is increase distensibility. Third and important is it will keep the alveoli dry. So alveoli dry. These are the three things important. So when it is increasing the ability to expand, so that means it will also decrease the ability to collapse. So decrease collapsibility. This surfactant, how it works. For that, we need to talk about one important law. That law is Laplace law. Which was the second point. Second point is increased distensibility. Distensibility means ability to expand. And collapsibility means the ability to go back to its original state. So over here, right, it will go back to its original state. The chances are less as compared to distensibility. So it will be more distensible. So that will, it will more expand. Clear? It will come. So in the inspiration, divide it into two parts. When at the start of the inspiration and at the end of inspiration. So we consider that what would happen to alveoli, what would happen to surface tension, right? What would happen to surface tension and what would happen to the compliance. What was compliance? What was compliance? Compliance and the elasticity. Right? Remember that compliance and elasticity, what we talked about. That's right. It is the ability or the measure how much it can stretch. So over here, alveoli is surface tension and the compliance. Elastance was that ability to return. Elastance was ability to return. So if you stretch anything, then you release it. So its ability to go back to its original state. That is the elastance. And this compliance is the measurement, measure of stretchability. So at the beginning, what would be the size of alveoli? Obviously small. And at the end of the inspiration, because air has gone in, so yes, that is true, it is large. That is clear. Surface tension, as it same as collapse. No. Stretchability and collapsibility, they both are totally different. Collapse means when that is elastance, right? Then it will try to go back to its original state. Stretchability means it can expand. Surface tension, when its surface tension depends upon the surface. So bigger the surface, bigger will be the surface tension. So yes, this is small, so there would be a surface tension. This is large, so there more surface tension. Compliance means ability to stretch. When the balloon is smaller, right, you try to inflate it, and then it will become bigger. So it means it has got capacity to stretch. So that means when it is small, it has got capacity to stretch. When it ends, so at one point of time, but more than that, it is not possible. It won't be expanded. So so these three basic principles of how it really happens. Now we talk about a bit of physics, and then we'll see some very interesting things. So yes, for next 2-3 minutes, this is called as the Laplace law. It is this law which will guide you not only for the heart, not only for the lung, but also for the heart and also for many of the chambers. Because this law is useful for any of the closed cavity. Any of the closed cavity. So given by Pierre Simon Laplace. Laplace is a name. Pierre Simon was the name of the person who gave this law. And what he said is that in the law of physics, if there is any hollow space or hollow tube, so how much tension would be onto the walls? How much tension would be on the walls? So tension on walls. How much would it? He said it would be directly proportional to the pressure which is generated by its content. Right? So pressure by its content multiplied by what is the radius? So that would be the radius multiplied by radius. Thus, that's it. This was the thing. These were the two things, right? Pressure by its content into radius. And this is the principle which was given by this person, Laplace. He applied it in medicine. So this is where it was applied to medicine. And see what happens. We will understand those complex things such easily. Okay, these are the X-rays which we'll be discussing. later on, before giving this file to you, I'll rearrange so that I'll put the exercise at time. So we write it again, that the wall tension on the wall is equal to what? Pressure. Pressure by whom? Pressure by the content which is inside, multiplied by the radius. Make sense? The radius, say this is the alveoli, the radius. Okay? Very logical. So pressure into radius. Let's break this down. We take it one by one. Here is the wall. Right? Let's say this is alveoli, or let's say this is one balloon. Right? We are just inflating it. So what would happen? We start pushing the air in. Right? So that is the pressure. This is in, this is out. So we try to push the air, and this one is pressure. Man, hang on. Now only 10 minutes is left. Just in 10 minutes we'll be able to. Let's not break the link at all. So this is the pressure. And then walls, there would be increase in the tension in the walls also, because the walls are getting stressed, right? So there would be the opposing pressure, and this is the wall tension. So that is how they are directly proportional. Okay? They are directly proportional. The balloon inflation, right? As the air goes in, the walls, they are trying to press it. So this is the first pressure. Now, you take a balloon, actually, right? Bilkul normal, brand new balloon, and you start inflating it. Fuk maro, right? You will find that initially you have to put so much of pressure. Aadha balloon full gaya. Uske baad when you put the pressure, easily it becomes. Right? Have you done that? The balloon, right? When it balloon inflation, is it difficult in first half? Correct. First half, and once it is partially inflated, फिर तो just right, and it becomes bigger. So this means what? That there is increased pressure when radius is small. When radius is small. In order to understand this thing, right, let's conduct one small experiment, and this thing will be crystal clear. We'll put some hypotheticals. So this is like tension on the wall, right? So wall tension is equal to pressure into radius. Let's say this is one kid, right? And this is his alveoli. And wall tension, we just keep saying that's the number 8. Right? And we don't know the pressure. And right now, this is the size of the alveoli. When the baby is not crying right now, the normal, right? So let's say this radius is 2. So how much pressure would it be? Pressure would be, obviously, now it would be 4, right? This much would be the pressure. This is the radius. It means it is this pressure which is 4, right? The pressure which is 4. That's the radius. That is 2. And this external pressure, which is onto the wall, is 8. So that's why everything is at standstill. And now the baby, when it cries, the baby has to generate more pressure inside, so that it inflates, it becomes bigger. It becomes bigger. Right? So this is, just consider that it is 4. Now, keeping the same wall tension, but now the situation is the baby has thoda ro liya, right? And now the alveoli has become bigger. Wall tension is the same. What would be the pressure if now the size has increased to The radius has increased to 4, so this is 4. So it will be just 2. That means that less pressure is needed when the diameter is bigger. In simple way, when we start breathing in, the initial phase, at the initial phase, next time we'll be drawing the graph. We'll be drawing the graph of all the diseases. So it will be so clear that this is how these graphs form. But if I draw the graph today, so it would be like when we start breathing, and as the pressure is generated, and then it will go and it will pick up. And initially, so there would be very less progress. So we are generating more pressure, and the air which is going is less. But as we as they become bigger, more and more air starts going. So it is not like a linear graph. It will be like this. So that is the important thing. If it is smaller, yes, that would be generating less pressure. Now, one small principle. I know this principle will be very important for the heart, but because we are discussing, so it will take up next. One thing, what is called as we talked about wall tension. There is something what is called as the wall stress. Wall stress. Wall stress means that pressure that if it gets generated, then it will break it. What happens in case of, let's say this is the heart, right? Very vital in case of heart, and this is the aorta. This is the left. Let's say there is aortic. Please mute someone. So that aorta, if there is aortic stenosis, what would happen? There will be increase in the left ventricular pressure. Right? Right? So when there is aortic stenosis, yeah, that's right. So then there will be increase in the left ventricular pressure. So when there is increase in pressure, won't it burst the left ventricle? Well, this is what would be explained into this wall stress. Wall stress is the wall tension. Wall tension on the wall. Wall tension is what? Laplace law, right? So the pressure into radius, right, upon 2 times the thickness. 2 times thickness. So this is wall tension, right? Wall tension, because we just saw Laplace law, pressure into radius and to 2. See how smart the things. Whenever there is such thing occurs, there would be left ventricular hypertrophy. Left ventricular hypertrophy. When there is left ventricular hypertrophy, so this, if you really see, the previous left ventricle was like this, right? Now what has happened? That its wall has become thicker. Wall has become thicker. The wall becomes thicker. Smart, right? It is the wall stress, right? Wall stress is equal to pressure into radius, right, upon 2 times the thickness. So this thickness has increased. When the thickness increases, wall tension decreases, right? Correct. And another interesting thing, see the radius. The radius has decreased. Radius has decreased. This is R1, this is R2. R2 is smaller. So this number decreased. Thickness increases, radius decreases. It's automatically the stress, wall stress decreases. Right. How wonderful. This is the reason that when this wall stress decreases, so heart is very less likely to blast, in spite of such severe aortic stenosis. If there is any aortic stenosis, so this particular heart will keep on generating the muscles bigger and bigger. So the wall thickness will keep on increasing. That is what is called as left hypertrophy. But when the walls are increasing, so at the same time, अंदर की chamber जो है, that size, that becomes smaller and smaller. So when it is smaller, as per the law, this number is decreasing, this number is decreasing, and this number is increasing. Yes, that is the point. That is to decrease wall stress substantially. So heart doesn't last or doesn't break open. So this is how it really works. Okay, now coming back to our X-rays. In the X-rays, the question which was asked last time, and I said that I'll talk about next time, about this area. This is the area which we'll be focusing on. I'll be showing you two important things. Every time I say one important golden principle. Today what we are discussing is called as the BVM, or the bronchovascular markings. Bronchovascular markings. You might have read X-ray report and in which it is mentioned that bronchovascular markings are normal or prominent bronchovascular markings are seen. Very simple thing. This is the lung. Divide it into three parts. One part, two part, and three part. BVMs, bronchovascular markings, not seen in the outer one. It is this, and this is. If it is seen, see over here. Can you see? This outer portion, no markings are seen. Over here it is seen. See, very all these markings. See, so many they are, right? They are. Let me zoom this. Right? You'll be able to appreciate. See, now see white lines. Then see, these are the bronchovascular markings. These are the bronchovascular markings. But where are these bronchovascular? Nothing seen over here. Because this is completely normal. Right? Same way over here. At this point, outer one third, no bronchovascular markings are seen. Bronchus vascular marking, that means this is the combination. All these things. This area is called as the hilum. So it is made up of combination of vessels and the combination of respiratory tubes. So that is what is called as the hilum. Now you see this. Yes. Right. So outer half, outer one third, no BVMs. And this is normal. So many things. Because if the bronchovascular markings are prominent, so that means right from the bronchitis, then there we need to see some other things also. But the commonest thing is that when the bronchi are dilated, so they are dilated, person is straining, and there will be several other reasons. So right now, just think it like, first I'm trying to teach you normal. Next time, I'll be showing you certain X-rays also. So COPD or the bronchitis, I'll show you asthma, and some of the cardiac conditions in which they become very common. Eisenmenger complex, etc. You will see that. But remember this basic principle, bronchovascular markings, right? They are not seen in the outer one third. This is one. You might come across certain number, certain terms. You need to be very scientific. So I'll tell you 8 terms today, in fact 4 terms. But it will improve your understanding of reading the report. Whenever you see the X-ray, in X-ray, things which are white, they are called as the radio opaque. Radio, and it is combined, it is called as the radio. Radio opaque means things are white. Opaque means through which something cannot pass. So here is the bone, right? If the X-rays cannot pass, so on the X-ray tube, right, they will not reach, this area will remain as white. This will look white. If X-rays they reach to this point and this thing turns black, so then it will look dark. So it is called as radiolucent. Remember the word radiolucent. So that's radio opaque and the radiolucent. When it comes to CT scan, things are pretty same. So, but over here, the word which will be used will be hyperdense. So in CT scan, if you see any of the white area, it will be mentioned as a hyperdense area of this particular size in this particular region. Hyperdense, that means it is white. When it is black, obviously it will be called as the hypodense. Makes sense, right? Hypodense. When you are doing ultrasound, so that means the sound waves are sent inside and they hit the object and then they are reflected back. When they are received back, so your transducer will receive those signals and they will be converted into the signal and they will be sent to the screen. So that means that area will enhance, will be bright, right? Because it has received hypo. White are bones and black are organs. We can't say black are organs, right? The organs which are consisting of air, right? So don't take that judgment. Many times, if there is any fracture, right? If there is any bone deficit, whatever, there is a bone and there are some round punched out lesion, right? So these are like lytic lesion. They are called as lytic lesion. Lytic means what? As if there are holes in at that particular bone. So that's why it is lucent. X-rays are passing. Try to understand the principle. Right? In general, you can say this in that white are bones. But technically speaking, don't take it that way. Because all the possibilities are. As the bone density decreases, this will tell you, right? When the bone density decreases, so the bone will become more white or more dark, blackish. It will be going towards this. It will become more radiolucent. Correct? Because previously the bone was so dense, nothing was allowed. Now the bone has become weak. So some of the X-rays they are crossing and they are reaching. So they generate some dark shadow. Right? So that's why they said that this bone is looking radiolucent. So maybe the bone density has decreased. Correct? Makes total sense. CT scan, it is called as hyperdense and hypodense. Ultrasound, as I explained, the sound waves are going, got reflected, and then they are coming back. Right? They are coming back. When they come back, that transducer has picked up and it is generated into signals. Then on screen, you see the bright areas. They are called as hyper echoic. Why echoic? Because echo means sound. We have received the sound, so that's why it is appearing white. If there is no sound received, no waves have got reflected, so that is what is called. It's the hypoechoic. So hyperechoic means from wherever it got reflected, but we got the signal. And over here, no signal was received. So that's why hypoechoic. And in MRI, magnetic resonance imaging, it is the magnetism, right, which is used. So that's why the technology which is used in this is totally different. That's why it is called as the hyper intense. So when it is said on MRI, you'll find these words. Hyper intense focus is seen in specific part of the liver. So that means there is a lesion, there is a focus, and it is white. Why it is white? Because it is generated. Then it is done like T1 weighted, T2 weighted, all those technology about how images are generated. But that's why they are absolutely diagnostic, right? And over here, it would be called as the hypoechoic. intense. Now, with this understanding, you will agree to that if we really look at this first X-ray, let's just remove these things. Look at the first X-ray. This is normal X-ray, right? It is normal. So these are everything right from the top to bottom. Can you say that there is very homogeneous, clear darkness? So there is homogeneous radiolucency because see, lungs are black, bones, right? See, these are the bones, these are the bones. But when you look at the lungs, right, only look at the lungs. So lungs are dark. If the lungs are dark, lungs are black, that is because of air. And there is homogeneous, right? It is not so that one particular area is very black and then this area is very white. Nothing like that. Nothing like that, right? It is totally fine, right? All the way from the top to bottom. So we can say that there is homogeneous radiolucency, right? Radiolucency. This is the stomach, right? Where this radiolucent area is seen, which is because of the air. And it is called as the gastric bubble, right? It is called as the gastric bubble. This is how you will be writing the report. Okay, now I'm showing you one more X. Over here, the blackness in this much portion and the blackness in this much portion. Is there a difference? Right? Blackness in this much portion and blackness in this much portion. Clearly, it is seen that yes, this area is more black and this area is less black. Right? If the area is less black, that means what? Less air. Simple. It is called as consolidation. Consolidation means what? That this is the tube. This is another tube. In this tube, there is full air. So that means this will be looking what? Radiolucent. Right? Radiolucent. Radiolucent means this would be black. But if there is less air, so this will look bit white, whitish. So that is not neural consolidation. Right now, I'm just telling you, consolidation means there is some collection, right? Air was unable to enter, but obviously, even that is a problem. Just see that. Yes, right? This is a female X-ray. This is X-ray of a female. You can see the breast shadow, right? And whenever in doubt, see this particular area and this particular area. They both are symmetrical. There is a similar radiolucency on both the sides. So what has really happened is that here is the lung air, but because of the presence of breast tissue, the amount of X-rays which were getting penetrated, they got decreased. And that's why this whitish pattern which is that is nothing but it's simply because of the breast of the female, right, through which the X-rays, the amount of X-rays which are penetrating through this area, they were different than area over above, and that's why this difference in the radiolucency. So just this is yes, that's right. This is a female X-ray chest. It's not. So that's it for today. I'll rearrange these X-ray plates in such a way that they will become like that when I'll save them. So see you day after tomorrow, same time. Thank you so much. And I'll be putting this into our shared folder. That is, just send a mail to me and send you the link. Send it to me. Thank you. Yeah. See you soon. Remember, I will be putting a respiratory system. Okay.
Timings?
Same time. All right. Take care. Bye-bye.
Thank you, sir. Bye, sir.